Hi, everyone. This is Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer, and I would like to thank all of you for attending this month's Journal Club. I also like to thank ESGO and IGCS for their support of our Journal Club. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We're recording today's discussion, and the recordings will be made publicly available. So participants with your cameras turned on may appear in the video recording. So we ask that everyone please keep your microphones muted so everyone can hear the presentations. If you're having any difficulties or questions, please send a message in the chat and our technical support team will assist you. We definitely have time for questions and answers, and certainly always we enjoy all the questions that come in through the chat. So please, I encourage you to ask questions as well. I wanted to, of course, obviously now introduce this month's lead article, which is Rewind the Clock on Positive Peritoneal Cytology in Endometrial Cancer. Does it predict prognosis in low-risk disease? By Diletta Fumagalli and Gretchen Glaser from the Mayo Clinic and Department of Obstetrics and Gynecology, Division of Gynecologic Surgery at Rochester, Minnesota. And Diletta is also now at the European Institute of Oncology in Milan, Italy. Really very, very excited to have you both on the Journal Club. I also encourage everyone, if you haven't listened to the podcast, please do. I think it's a really fantastic opportunity to discuss this very, very important topic. So Diletta, Gretchen, thank you so much for joining us today. And now I'm going to hand it over to you for a summary of the article.
Yeah, thank you so much, Dr. Ramirez, for having us today. It's really great to be here. Let me just share my screen. Yeah. Oops. All right. So I will start with the presentation. Today, we will cover the role of positive peritoneal cytology in endometrial cancer. And specifically, we will focus on the prognosis and the prognostic impact of positive peritoneal cytology in low-risk disease. So in general, the presence of malignant cells in cytologic analysis of peritoneal washings is defined as positive peritoneal cytology, and that has been associated with worse outcomes. And that has also been recognized by international guidelines. But also, the ESGO and NCCN guidelines state that there should be no influence on adjuvant treatment based on positive peritoneal cytology. Still, there is some contradictory evidence on this matter regarding the usefulness of taking the peritoneal cytology, and of course also the impact of cytology on prognosis in endometrial cancer. And so this uncertainty led us to our aim. So to evaluate the role of positive peritoneal cytology in predicting 5-year recurrence-free survival and overall survival in patients with endometrial cancer. And also, of course, we decided to have a specific focus on those patients that are considered at otherwise low risk of recurrence. So moving to the methods, this study was a retrospective cohort study. We included patients that were treated at Mayo Clinic in Rochester, Minnesota from 1999 to 2021. And as you can see here, our overall population included 3,517 patients that had their surgical procedure done at Mayo Clinic. We excluded those patients that had neoadjuvant chemotherapy, that had synchronous cancer, unknown cytology, or that did not consent to the use of their data for research purposes. So first, we performed an analysis on this big group, and then we moved to 2 low-risk cohorts. The first that we called NCCN low-risk cohort that included stage 1 disease, endometrial cancer, and low grade, so grade 1 and 2. And then we also identified another low-risk cohort that we called ESGO low-risk cohort based on the ESGO guidelines. So stage 1A disease, endometrial cancer, again, low grade. And this time we also added another characteristic, so no lymphovascular space invasion. So as you can see, there is a partial overlap. So basically the second cohort is part of the first cohort, but we really wanted to focus both on both the low risk groups as identified by the major international guidelines. We performed univariate and multivariable regression models to test the association of positive peritoneal cytology with recurrence events. And we also concluded our survival analysis with the Kaplan-Meier method for overall survival and recurrence-free survival. Oops. Okay, so here we're moving to the results. So as I mentioned before, we also performed an analysis on the general population, but we decided to move this part in the supplementary materials. In the article, we really focus on these two low-risk groups. So having a look first on the first cohort, so the NCCN low-risk group, we had 1,911 patients in this cohort, and we found that 154 patients had positive peritoneal cytology in this first cohort, so approximately 8% of the cohort. And we found that increasing age, tumor grade 2, and positive peritoneal cytology were associated independently with recurrence. And then we also found that the recurrence rate, the 5-year recurrence rate, was 6.5% in the positive peritoneal cytology group versus 2.8% in the negative peritoneal cytology group. And then moving on to the second group, so the ESGO low-risk cohort, again, same characteristics as before, but no lymphovascular space invasion. We found that we had 1,835 patients in this group, and we found that 145 patients had positive peritoneal cytology. So again, approximately 8% of the cohort. We found again that increasing age, tumor grade 2, and positive peritoneal cytology were independently associated with recurrence. And we also confirmed that the recurrence rate was 5.5%, so quite similar to the previous one in the positive peritoneal cytology group, and it was 3% in the negative peritoneal cytology group. So moving to the Kaplan-Meier analysis first, we had an analysis on overall survival that was not statistically significantly different. So there was no difference between the positive and negative peritoneal cytology groups as per the overall survival analysis. And this has not been reported here for brevity, but I will show you then the recurrence-free survival analysis. So in the NCCN low-risk group, the 5-year recurrence-free survival rate was almost 96% in the negative peritoneal cytology group, and it dropped to 89% in the positive peritoneal cytology group. And this difference was statistically significant, as you can see here also from the graph. And then we move to the ESGO low-risk group. So again, the 5-year recurrence-free survival rate was 96% in the negative peritoneal cytology group, and it dropped to 90% in the positive peritoneal cytology group. So again, this was also statistically significant. So to conclude, positive peritoneal cytology was independently associated. So it was an independent predictor of recurrence in patients with low-risk endometrial cancer, both according to the NCCN and the ESGO guidelines. And of course, positive peritoneal cytology was associated with worse recurrence-free survival. But it also has to be underlined that the recurrence events were few. So not a lot. The overall survival was not impacted. And of course, we're talking about very high also recurrence-free survival rates. So where do we go from here? What are the future steps and the future implications of this study? So we believe, first of all, that patient counseling can be personalized based on our results, but we also feel that there is no current evidence to recommend adjuvant treatment based solely on positive peritoneal cytology. And we advocate for future investigations on the role of positive peritoneal cytology, especially in molecularly classified endometrial cancer. So thanks a lot for your attention, and yeah, we'll take your questions.
Diletta, thank you so much. That was a wonderful presentation and really very helpful slides as well. And before we start with a question, I wanted to kind of just start with just a basics with regards to the technique. And I'd love to hear from Gretchen as well with regards to these cases of endometrial cancer when operating on these patients. Do you do anything to potentially prevent cells from coming out through the tubes into the peritoneal cavity? In other words, like in the past, there was this thought of coagulating the tubes and doing anything to potentially prevent that positive cytology from any type of mobilization of the uterus.
Yeah, that's a great question. We do not do anything like coagulating the tubes at Mayo Clinic. However, we don't use manipulators. That really started back before we had data showing that there wasn't a difference in survival, whether you used a manipulator or you didn't, and you had positive peritoneal cytology for manipulator versus not. But in this cohort, there were no manipulators used. I think some of us still feel like we don't want to use a manipulator, but we know there's no science behind that. But yeah, at Mayo Clinic, we do not use manipulators.
Excellent. All right. Yeah, and I'm sure that we'll be discussing manipulators in a while as well from some of our questions and from the fellows. So with that, then I'm gonna turn it over to our fellows, and I believe the first question is coming from Luisa Prope from the University Hospital in Münster.
Yes, thank you. And thank you for the presentation of this exciting project. So some of your patients with positive cytology received adjuvant therapy. So how do you think this bias influences your study results?
It's such a good point. Yeah, I'll take that one. It's such a good point. And certainly is, one of the biases in this study. However, there was a small number. So that's what we kind of think of. We think there was only a few people who underwent adjuvant therapy, about 5%. And systematic adjuvant therapy or systemic adjuvant therapy may have improved the prognosis of those patients, but because there were so few, we feel like it probably had a minimal impact on the results. There's just been change in practices over time. As you can see, this study ranged from 99 to 2021. And there was a thought, especially in the early 2000s, about giving systemic therapy for peritoneal cytology that was positive. So we definitely recognize this, but because it's a small number, we think probably minimal impact to the outcome of the study.
Excellent. Thank you so much, Luisa, for that question. Very good question. And again, I'd like to encourage those of you who are participating. We have over 35 people in the journal club to also submit your questions. So we already have one question in the chat. Albert Jacob is asking, congratulations on this interesting study. It's great to take a step back and reconsider decisions in our guidelines. I was interested in the sites of recurrence in the positive peritoneal cytology. Was it more of local or these were distant recurrence? And was the cytology from acidic fluid or from washings?
Yeah, so actually we had, so of course the numbers are very low. So we could not compare the numbers, for example, of the recurrences in the negative cytology group and the positive cytology group. But we definitely saw a trend with more isolated vaginal and isolated peritoneal recurrences in the positive peritoneal cytology groups in the low risk cohorts. And yeah, it was a retrospective study in a time frame that was very long, from 1999 to 2021. So it was a bit difficult to ascertain if it was acidic fluid or washings. So we don't know that, but we could probably think that it could be more washings, since the cases that we're talking about are low risk. So it's not really expected to have like a lot of ascites. Of course, there might be some fluid in the peritoneal cavity, but yeah, this is just inferential actually, because we have no information on that.
We don't hear
Thank you
you.
so much, Diletta, for that. For our next question, we're actually going to go right near your own institution, from Marina Rosanu from the European Institute of Oncology, Milan.
Thank you for your great presentation. So this is a follow-up question to the previous one. The study spans more than 2 decades, during which the FIGO staging system was modified, specifically with the removal of peritoneal cytology from the staging in 2009. Combined with the absence of molecular classification, how might these evolving classifications and practices have influenced the interpretation of the prognostic significance of positive peritoneal cytology in this cohort?
Yeah, thank you, Marina. So again, the study period is very long. So we know that there is, of course, a bias because things could have changed and have changed in this time frame. But it's also true that we focused on a low-risk group of patients, and little has changed in this group. So their surgical procedures were the same, and they were in 95% of the cases, they were counseled about surveillance, not about adjuvant treatment. And so to me, in our opinion, actually, we think that the most important confounding factor that we haven't measured was molecular class. So that is for sure something that is worth looking into.
Excellent. We have another question from our audience, from one of our former fellows, Alexander Shuskevich from Ukraine, and he's asking, thank you so much for your great work. May I ask if you stratify the patient groups for laparoscopic versus open surgery? And if so, were there any differences?
I can take that one. So we did, in our univariate analysis, separate out open surgery as the reference group, and then we had minimally invasive surgery as the experimental group, and that included vaginal, robotic, and laparoscopic, and LAVH, actually. So we basically took anything that wasn't an open incision and put it in one group, and there was no difference in recurrence-free survival over 5 years between the two, the p-value of 0.41.
Excellent. Very well. And we'll turn it over now to Natalia Tejeda from the Hospital Clinic de Barcelona.
Hello, thank you very much for the great presentation. I was actually going to ask about the higher rate of positive peritoneal cytology you found in patients who had minimally invasive surgery. Because somewhere in the discussion, I read that you have hypothesized that this could be related to the use of uterine manipulators. But if I understood correctly, you said that in this cohort, no uterine manipulator was used. So if it's not the uterine manipulator, what else do you think could have explained this?
I actually wonder if in the early 2000s, when we were just starting laparoscopic surgery, so we used manipulators then, but then when some of the data started coming out that this increased peritoneal cytology, we stopped. And so we haven't used them in many, many years. Like I would say at least since 2010, maybe 2009 even. But in those first years, I bet we did, when we were all kind of getting used to the laparoscopic version. Since then, there's been several studies published that there's no association. There was even a meta-analysis in 2024, which showed no association between minimally invasive surgery and positive cytology. So, but in our group, as I was saying, practices changed so much over time, and we have 9 surgeons in our group, and of course, the surgeons have changed over time as well. So we don't know exactly how many were using manipulators back then, but certainly that could have contributed, because we know that there is an increase in positive cytology with manipulator use.
And Gretchen, if I can follow it up with regards to the use of manipulator or not use of the manipulator, I think probably one of the biggest contribution of the manipulator is at the colpotomy that helps you delineate that. So if not using the manipulator at the Mayo Clinic, what do you use to actually perform the colpotomy?
Yeah, we used an acrylic probe. So we have they're actually made at Mayo. We have a whole department that makes our own devices. And so they've made us a set of these devices. When I was in practice in a different place for a few years, I tried using the Apple probe as well. I would not suggest using a metal Apple probe because that causes a lot of sparking. But I was able to find a ceramic metal probe and order some of those, so that can work as well. But yeah, we use acrylic dilators, manipulators. We use them different size based on the size of the vagina. So we basically use the biggest one that the vagina will accommodate. And then we have someone kind of push up the whole cervix and uterus. We actually do that right before we take the uterines as well, to make sure that we have the uterines and the ureters far apart.
Excellent. Very well. All right. So we go back to Italy. Filippo Capomacchia from Candiolo Cancer Institute in Italy.
Thank you. So in your study, you mentioned that molecular classification was not evaluated due to limited data availability. Could you specify for how many patients the molecular profile was actually available, if you conducted any preliminary analysis, and what findings you anticipate from integrating peritoneal cytology status with molecular classification in the prognostic stratification of low-risk endometrial cancer patients?
Yeah, I'll take this one. So fortunately, molecular classification was not available for consecutive cases. So it has been performed at Mayo in very specific clinical settings, for example, recurrence. And in research settings, again, it was not on consecutive patients, but in very specific patient populations. And for this reason, we haven't performed a preliminary analysis on this. There is one study by Villiger and colleagues that we also discussed in our commented on in our discussion. And so based on their findings, we can hypothesize that peritoneal cytology has an impact also after stratification for molecular classes. And for example, we could also expect to find this the positive peritoneal cytology as occurring more commonly in more aggressive molecular subtypes, like, for example, P53 abnormal and NSMP. But however, like, this is now only inferential because we have very limited proof of this.
Excellent. Thank you so much, Diletta. And we'll stay in Italy, and I'll let Giuseppe ask the question. Giuseppe Cucinella. Giuseppe, thank you so much for joining. It's great to see you.
I'm glad to see you. And first of all, I want to send a big hug to all my friends from Mayo, and really, really congratulations for the great job. Outstanding. Just one point of discussion is about the real clinical significance of the peritoneal cytology. And you just say that there is no impact on overall survival. And also looking at the site of relapse, there are few numbers for sure because it's low risk, but they are isolated in the vaginal or in the peritoneal. So it seems that it's like the usual kind of site of recurrence that we have in endometrial cancer. So the point is, how can we interpret and use this retrospective data to apply that in the clinical practice? Also because we now have to integrate it with the molecular analysis. And so the point is, maybe we can use it to change our follow-up, because maybe this recurrence-free survival is impacted. So maybe we can change the follow-up. And so maybe we need to design a prospective trial, as we've done for the ITC, to look in a prospective way how it's going. And it's also, I don't know if there are guys from Belgium, that the Eugenic trial is incorporating also data of the peritoneal cytology. So maybe this is for sure is a prospective evidence So just it's a point of discussion. I don't want to put anyone in the corner, but thank you, everyone.
Any comments, Gretchen, Diletta, to Giuseppe's comments?
Yeah, I think it's a really great point that I would treat this like a signal. Like it's we need obviously prospective validation. A prospective validation would be amazing. So we're currently doing the endo ITC trial, basically collecting patients prospectively. I get to put a little plug in for this.
He set you up perfectly.
You really did. Thank you, Giuseppe. So yeah, we're doing an endo ITC trial, basically collecting patients with positive ITC and otherwise low risk disease. And going forward, I think a very similar thing would be appropriate here because again, it's a small number and we don't know exactly what the change in prognosis would be. I do think, you know, for the endo ITC trial, we are following patients a little more closely. The patients who were in this study, in our current follow-up mechanisms, they would probably be seen at 6 months, a year, and then yearly after that. And maybe if they have peritoneal cytology, we treat it a little more like watching them a little more closely. In the endo ITC trial, we're doing CT scans a little bit more frequently. That might be an appropriate thing to do, see them every 6 months and get a CT scan every 6 months for the first few years. I think, you know, things that we can do that are low risk to the patient that we can also use this signal would be really good.
Excellent. Well, thank you, Giuseppe, for that comment. So now we're back to Italy, Padova University Hospital, Sofia Bigardi.
Hi, thank you. So my question is, considering the independent association between positive peritoneal cytology and recurrence in low-risk patients, do you believe cytology could be reintegrated into risk classification tools or clinical decision-making in association with the molecular classification, or could be useful also in center without access to molecular testing?
Yeah, great question. You know, that's the trouble with doing a retrospective study that spans so many years is that we don't have, you know, we may have information from now that we didn't have before, or we even have more information now 4 years later from when we stopped collecting that we didn't have then. So I would love to combine molecular analysis with this, either to, you know, look at molecular analysis on purpose for patients who have positive cytology, or to combine a higher risk, let's say they're P53 abnormal and positive cytology, combine those to change the follow-up regimen, that sort of thing. You know, if it is an independent risk factor and we're considering it an aggressive independent risk factor, something we could confirm on a prospective study, then I think it would make a lot of sense, you know, to make molecular classification decisions based on that.
Okay, we'll turn over to Clara Santia from Houston Methodist and now heading over to Argentina very soon. So Clara, do you want to ask your question?
Perfect. Thank you so much. And congratulations for the authors for this incredible study. My question is, do you have any data on how these patients were initially diagnosed? Specifically, was DNC or office-based endometrial sampling used? I'm asking because the use of DNC could potentially contribute to cell migration into the abdominal cavity. Thank you.
Yeah, great question. Diletta, do you want me to take this one since I'm...
Oh, it's all right, as you prefer.
Okay. Yeah, so I'm really deep in the practice here, so I thought I could, you know, there are 3 different ways these patients were diagnosed, either office biopsy, office hysteroscopy, or DNC, and we didn't stratify them out. So I'm not sure, you know, we don't have that information about how they were diagnosed, but for sure, those are all 3 ways they were. Also, a lot of these patients come from outlying facilities, so we don't know exactly how they were diagnosed there. And for sure, that could contribute to cell migration.
Excellent. So we'll get back to our fellows, and this time we go to Sao Paulo, Brazil. Mariana.
Thank you so much. Congratulations on the presentation. So how why do you think there are so much inconsistencies in the topic of positive peritoneal cytology?
Yeah, thanks for the question. That's a tough one. So there are a few studies, several studies actually on peritoneal cytology and its role in endometrial cancer. But these studies have very often they have a different focus. So they focus on different populations. They have different study designs. Sometimes they also focus on the same population, so low risk cohorts. There are a few that focus on this population, but the setting is different. Sometimes the data collection is different. Sometimes also the adjuvant treatment is different because sometimes positive peritoneal cytology prompted adjuvant treatment. And so that's very difficult to have a final conclusion, a definitive answer on the role of positive peritoneal cytology based on the evidence that we currently have. And I also wanted to mention that there are also studies that are based on national databases, like for example, the National Cancer Database. But again, we have limited data. For example, in a study that is based on the NCDB, there is no information on LVSI, and that was also a potential confounder. So yeah, the perfect study doesn't exist. And yeah, probably this is the overall explanation of how there and why there are so many inconsistencies.
Excellent. So turn back to the questions from the audience. Alexander, you want to ask your next question?
Yeah, thank you so much, Pedro. Yeah, I'm just wondering, we know that the risk of recurrence Can you hear me?
Yeah, now we can. Go ahead.
Yeah, thank you so much. I am just wondering, we know that the risk of recurrence is twice more. So my question is, how do you think, do your findings have any potential impact on fertility-sparing treatment options for this cohort of patients? Should we consider, I would say, diagnostic laparoscopy with peritoneal washing before the treatment, before the start of this treatment for this patient?
Interesting.
Yeah, so that's again very difficult to say based on the evidence that we have now. We do not know if in the setting of fertility sparing treatment for endometrial cancer, there is any role of positive peritoneal cytology. As far as I know, there hasn't been any study focusing on this exactly. So my suggestion would be, first of all, to confirm this hypothesis. So the fact that positive cytology has an independent impact also with molecular classification. And then, yeah, we could also potentially study this. That's actually very interesting.
Yeah, I love the fact that out of these journal clubs, I'm pretty sure there's like some additional studies that come out. So
yeah, we should take notes.
there's the race to the design of that next study. So now we'll turn over to Helena Obermeyer, who is joining us from Sydney, Australia.
Thank you. Based on your findings, do you believe peritoneal cytology should be routinely collected during staging for low-risk endometrial cancer?
I might be a little biased because I'm at a place that never stopped, but I think all things considered, it is fast, it's easy, it's pretty inexpensive, and we're not 100% sure that it doesn't affect prognosis. And we're seeing here in this study that it might really affect prognosis. And so I would say do it. Do the wash.
There you go. Excellent. So we'll turn over now to Heidelberg University Hospital. Frederic Stroich.
Thank you for your presentation. Your results, you would
wait
counting low risk endometrial carcinoma and negative. Oh, you can't hear me?
No, it's connection is not great. You want to try it again?
Sorry. Yeah, I tried. Yeah, thank you for the presentation. So based on your study results, is there anything you would change in daily routine when counseling patients with low-risk endometrial cancer and negative or positive peritoneal fluid?
Yeah, so definitely there is the possibility of changing our counseling based on these findings. So for example, when we counsel a patient on their histopathological and cytological at this point results, in the past, we used to tell them that the cytology made little difference, right? So there was basically no influence on their recurrence rates, on their risk of death, for example, and the overall risk of recurrence based on this. But now we can tell them, for example, if they have positive peritoneal cytology, that there's a little increase in their risk of recurrence, but overall their risk of death because of the disease is not impacted. And so I think that this can have two effects on the patients. First of all, in the case of a patient that has positive cytology, they can be counseled about being more precise with their surveillance program and come to the visits and do the consultations and their checks as recommended, but also that this finding is not a sentence of death or having high risk of dying because of the disease. So it can also be a reassuring point.
Fantastic. Thank you, Diletta. And we'll go to Albert. Do you want to ask your question, Albert?
Yeah, sure. So I just wanted to know whether there's any way we can differentiate cytology, like on cytology, whether we can differentiate whether the cells are from a metastasis or they might just be cells that might have washed up and got there, maybe supposed by during a hysteroscopy, like cells might have got washed from the tumor, something like that.
Okay, thank you.
I think we could use, just clinical information for that. I think, there's not a good way histologically to tell the difference between a metastatic cell and a cell that broke off during a hysteroscopy, for example. But you could look at that patient and say, did they have a hysteroscopy to diagnose and kind of get some information that way? Yeah, that's what I would say. That's the only way to tell the difference. I think most people, us included, who do washings before hysterectomy do it before we do anything else. So the likelihood that there was contamination during the surgery would be really low.
Excellent. And we'll have one last question from the chat before we get to the last question from our fellow. And from the chat is Priyanka Singh, and she's asking, would you recommend peritoneal biopsies instead of cytology?
I could take that one. So we know that in ovarian cancer surgery, we used to do tons of peritoneal biopsies. So we actually at Mayo, we had a whole metal plate made where we would put each of the peritoneal biopsies we took, from the serosa of the small bowel, serosa of the large bowel, mesentery of the small bowel, mesentery of the large bowel. And we know that in those patients, it made no difference in their diagnosis. And I'm concerned that and that was in areas where there was no visible disease. I'm concerned if you take a biopsy in an area with no visible disease, you're going to have the same outcome. So no effect, because what if you biopsy one little area and right next to it, there's disease, but you biopsied a negative area. So I think peritoneal cytology gives us the best chance to find positive cells because of the circulation of the fluid in the abdomen and the likelihood that if it's anywhere, it's going to be in the fluid.
Excellent. And we'll turn over now to Rim Abu Chakra from Lebanon for the last question from our fellows.
Hi, thank you for this presentation. A lot of areas do not have the resources to do molecular testing. Do you think in that sense, using positive peritoneal cytology could guide us for adjuvant treatment?
That would be amazing. I would love that, but I just don't think we're there. I think we need some prospective data to give us more information. I think with a retrospective study, It's very and no integration of type of adjuvant therapy and all that kind of thing. It's really difficult to integrate that treatment decision. There was one study that we did at Mayo when we were using Mayo criteria before sentinel nodes to look at whether you could, in places without frozen section, just open the uterus and take a look, and what would those criteria be for deciding whether or not to take nodes. You could do something similar with this to like design maybe a follow-up system for people who have positive peritoneal cytology, but I don't think we're there to recommend adjuvant therapy in places without molecular testing.
Well, thank you both so much, Diletta, Gretchen. It's really been a very enlightening discussion of this topic, this manuscript. I want to thank you for accepting our invitation to the Journal Club. Congratulations to both of you and the rest of the co-authors on this work. Diletta, you did a fantastic job on your Journal Club as an author, and Gretchen, thank you. Great having you back on the Journal Club as well. So I want to also thank the fellows for turning in, writing their questions, and all of you who attended the Journal Club and sent in your questions. I also want to remind everybody for the upcoming Journal Club, next month it will be on a manuscript titled Outcomes of Minimal Residual Disease at Upfront Debulking Surgery Compared with Complete SADA Reduction After Neoadjuvant Chemotherapy. So once again, thank you so much. Diletta, we're looking forward to receiving you here in Houston Methodist. So it's great to see you all. Thanks to all of former fellows who have joined in as well. It's great to see you. Thank you.
Thank you so much, Dr. Ramirez. This was wonderful. So fun.
Thanks a lot, Dr. Ramirez. Great to see you all.
Have a good day.